Hello, everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Optimizing Rapid Response Teams to Save Lives, New Technologies and Early Warning Systems. And now, without further ado, I'd like to introduce you to Lynn Healy, who is doing double duty as a speaker and is also serving as our moderator today. Lynn is currently the Clinical Project Lead for Clinical Alerts at William Osler Health Centre in Brampton, Ontario. Lynn's clinical focus is on patient quality and safety, and Lynn has been a clinical champion for early warning systems at William Osler since 2013. In 2015, Lynn was the recipient of the National Bank Bursary Award in Clinical Excellence and Professional Development. Lynn, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Yes, Emily, I'm ready. Thank you for the introduction. I'd like to introduce one of the speakers today, Dr. Michael Milliton. Dr. Milliton is a staff intensivist and respirologist at William Osler Health System in Toronto, Canada. He has served as medical director of critical care at William Osler and has implemented rapid response teams in 2 large community hospitals. His clinical interests include knowledge translation in the intensive care unit, telemedicine applications in acute care, and the design and deployment of early warning systems in hospitals. Dr. Milliton pioneered the early warning system currently at use at William Osler Health System. The speakers have disclosed no conflicts of interest. There is continuing education for nurses and respiratory therapists. This educational activity is approved for 1 contact hour. A link to obtain CE credits will be available at the conclusion of the webinar. Support for this educational activity is provided by Philips Healthcare. I'll turn the slides over now to Dr. Milliton, who will continue the presentation. Dr. Milliton, are you ready?
I'm ready. Thank you very much, Lynn, for that kind introduction, and hello from Canada. I'm Michael Milliton, and pleased to be speaking with you today. We're going to talk about ways we can optimize the function of our rapid response teams, and talk a little bit about new technologies and really focusing on early warning systems, which are becoming increasingly popular throughout North America, Europe, and Australia. Learning objectives. On completion of this activity, the participants will be able to, 1, describe the differences and similarities between the commonest types of early warning systems currently in clinical use, and number 2, describe how early warning systems can optimize the functioning of rapid response teams. Now, as some background, we know from literature and certainly in our own center mirroring that, but 30%, up to 30% of admissions to medical intensive care units are unplanned admissions from the wards. And those types of patients typically are the leaders in terms of mortality rates in the ICU. They tend to drive that. In our center, patients who come from the wards to the ICU in an unexpected, unscheduled way have doubled the mortality rates compared to our patients admitted from the ICU from the ED or post-operatively from the PACU. And those patients have a mortality rate around 30%. From the ED, most national surveys, it's around 10 to 15%. From the PACU, it's often very low, but 1 to 5%, depending on whether those are scheduled or emergency surgeries. So those are all comers to the ICU, and in those all comers from the ward to the ICU, we have a variety of or a gradation of severity. They tend to be pretty sick, but at the most acute end, we have those who actually proceed to cardiac arrest or code blue on the wards, and their outcomes are unfortunately completely dismal. Cardiac arrest, which occurs in hospital, usually is due to a non-shockable rhythm. It tends not to be VT or VF, which can often be shocked and has a better outcome. Usually these are asystolic arrests or PEA arrests, and they're usually the end stage of a disease process which is unrecognized or not responding to therapy. And so this is not what we'd say is a let's say, purely cardiac arrest, but maybe the end result of a systemic problem. Warning signs for that are not subtle. The outcomes are dismal. So survival to discharge in large studies looking in the United States, around 13% for people who experience an in-hospital cardiac arrest. Of those people, 13% who survive, about 50% have disability and 22% have severe disability. And we've seen an increasing burden in the United States and Canada of neurologic disability in these survivors over the last decade. So what are predictors of these bad outcomes? Well, we know that about 80% of ward patients requiring an ICU transfer that's not expected have 3 or more service criteria present when they're on the wards. And I've just reviewed those service criteria for you, and I think most of you are aware of what those are. Most of the other 20% have alterations in their level of consciousness, so change in their Glasgow Coma Scale or delirium. Vital signs are the key to diagnosis of a deteriorating patient on the wards. The most important vital sign is also the least accurately reported in the literature. We know this, and it is a challenge. It takes some time, it takes some observation, and it's the respiratory rate. And the respiratory rate is a really nice vital sign because it tells us about the respiratory system and the circulatory system. So we know that almost any lung problem will raise the respiratory rate. A low respiratory rate we can see with intoxication sometimes, but a high respiratory rate is often the body's response to acidosis. So if a patient's circulatory system is not working well, if their blood pressure might be low or seemingly normal but maybe too low for them, as that lactic acid level rises because of impaired organ perfusion, the respiratory rate will rise to offset that acidosis. And so the respiratory rate might be a nice clue. Even if the lungs are normal, a high respiratory rate may give us a clue as to a circulatory problem that might otherwise be occult. That may have a normal blood pressure until the very end. We do see that sometimes in our younger patients. So if we could think about a pathway and imagine the path with a deteriorating patient on the ward, and we have these little signposts along the way. So we have a stable patient developing some abnormalities and vital signs I talked about in the last slide. And the next thing we find is the vital signs get more abnormal and the patient starts meeting calling criteria for rapid response team. So needing loss of oxygen, very high or very low heart rate. Some centers use blood pressure as a criteria, tachypnea, altered mental status. Those things occur, and then finally, through one way or another, patients recognize to be sick enough, they end up in the ICU. If they're not recognized early enough, they might proceed to a code blue and to death. If we move back along that pathway to the earlier time when the patient's stable and first develops abnormal vital signs, we can potentially intervene at that time using an early warning system, even before the rapid response team is activated. And taking this entire pathway as a whole, on average, got about 24, 25 hours there from stable patient to ICU admission or bad outcome. There's a variation there. Some patients progress through this very quickly, others longer, but on average, often there is time. So abnormal vital signs occur and usually don't lead directly to a bad outcome right away. Usually you've got time to intervene. When we first designed our early warning system, I thought, boy, we're going to get these alerts once abnormal vital signs occur. We're going to respond. We're going to run to the patient's room and intervene and do all these great things and save their life. But what we noticed, in fact, is we had time. Not that we were moving at a snail's pace. We're definitely intervening with these patients, but we had some time to stop and think, review things, speak to the right people, talk to the patient, talk to their families. This was not usually a code situation. So that's the nice thing about this. That's one of the nice things about this. So what do we do typically now to respond to a deteriorating patient on the medical or surgical wards? Rapid response teams have now become widespread throughout the developed world and other places too. The evidence base for their justification is maturing. Early warning systems are a bit newer, but they have now become the standard of care in the United Kingdom. There's a rapid uptake of early warning systems in Australia, and they are starting to gain popularity in the United States and Canada. The evidence base for their effectiveness is small, but it is growing by the week. So what do we know about the functioning of rapid response teams? Call it the good, the bad, and the ugly. Got lots of encouraging data. In general, the busier the rapid response team, the better the outcome for ward patients. And at our center, we were able to replicate this famous activity versus code blue curve, and I'll show you on the next slide. So if you've ever been to a talk about rapid response teams, you've probably seen this graph or this curve. Rapid response team deployments have been associated with decreased number of code blues, decreased hospital mortality, and lower illness acuity at the time of the ICU admission in several studies. So the thought being that if you intervene early, rapid response team comes see the patient, decides to admit them to the ICU, the patient will be less sick at the time of ICU admission because they've been picked up earlier. And here's the curve I've been telling you about. So it's from the pioneers of rapid response teams in Australia, and it shows you the number of MET calls or medical emergency team calls, rapid response team calls per 1,000 admissions. And it shows that the busier you are, the more calls you get, the greater the reduction in cardiac arrests. And we've seen this both ways at our center. When the rapid response team is busy, the number of cardiac arrests goes down. In quarters where our rapid response team, for whatever reason, is not so busy, guess what? The cardiac arrest rate goes up. So not all studies are positive regarding rapid response team. A large review of rapid response team patient outcomes from 2017 showed that still about 30% of patients who have a rapid response team consultation die in hospital. And I think that speaks to the acuity of these patients. I mean, who gets a rapid response team consult? Those who are recognized to be sick on the wards. The MERIT trial, a lot of talk about this. This is now an old study, over 10 years old now, again, done by the Australians who pioneered rapid response teams. And what they did is randomize hospitals, 10 or 12 hospitals, to have a rapid response team or not. And they showed no difference in the end. Their patient outcomes did not differ between those hospitals that had rapid response teams and those that did not. And that led to a lot of angst and a lot of head scratching as, hey, why did this trial of something that we know at the bedside makes a difference, why didn't it show a difference in this randomized control trial? The authors did something very clever. They went back and they looked at, how good were these calling criteria that many of us around the world now use. Calling criteria that you use to trigger a rapid response team response or call. And they looked at how good those criteria were to predict cardiac arrest and ICU transfer, death, all the bad outcomes. And the sensitivity was incredibly poor. So the specificity was very good. So if you met those calling criteria, something bad is probably going to happen to you. But these criteria missed about 50% of people who went on to have a bad outcome. Part of that poor sensitivity was not just that the criteria may have been set high, meaning by the time patients breathing really fast or the time the patient's got a really fast heart rate, for example, they're already pretty sick. Part of the poor sensitivity was that calls weren't made. So when they looked back and said, okay, who really had these criteria present? Well, when they looked at all those patients, only half of them ever had a call made to the rapid response team. So the bottom line is rapid response teams were not activated as frequently as they were needed to be. So we can now think of this concept of dose of rapid response team. So if you're part of a rapid response team, think of yourself in a big syringe and someone's pushing that syringe and you want to be dosed appropriately, because if you're underdosing, your rapid response team response, you're not going to see those good outcomes that you want to see. You're not going to improve outcomes on the ward. So when there's an increasing time between calling criteria met and rapid response team activation, so calls made, but there's a big lag time, that's associated with increased mortality with an odds ratio of 2.5, so 2.5 times more likely to die if your call is made too late. If the rapid response team is not activated at all for a patient who does meet criteria, again, there's 1.5 times chance of dying if that occurs. And these are just 2 studies, and there are several others that show the same thing. This is a pretty consistent signal. So in summary, if no one calls at all, your patient could end up with a code blue and at near certain death. I showed you the outcomes earlier for in-hospital code blues. If no one calls for a while, they call, but they took their time for a variety of reasons, that might lead to an unplanned ICU admission and, again, a high risk of death. So on the wards, no one can hear you scream sometimes, and we need to fix that. So these problems have led to articles with titles like this, The Rapid Response Team Paradox. Why doesn't anyone call for help? This is by Michael Bleast, an Australian physician, one of the pioneers of rapid response teams, and you can hear the angst in almost feel or hear the angst in this title. Someone who's dedicated a lot of time and part of their life to operationalizing rapid response teams throughout the world, and then realizing, hey, no one's calling us enough. So why does this happen? Why do we underdose our rapid response teams? So activation of rapid response team or medical emergency team depends on a lot of things. Staff at the bedside have to be accurate in their observations. They have to make a judgment about the patient's condition. They need to be diligent in the measurement of vital signs, and they need to call for help in a timely fashion. Often our systems are siloed, so rapid response team providers have only limited means to change this dynamic. Rapid response team providers are typically not at the bedside. They are often in the ICU. They may be covering an entire hospital. They can't be everywhere all the time. And so there is a bit of that siloing. We do a lot of education, get out there, talk to our ward providers a lot, but in the end, we're relying on those ward providers, nurses, RTs, physicians, families sometimes, to make that phone call. So 12 years after the MERIT study, when we look at our no-call scenario, so patient has criteria but calls aren't made, many medical emergency teams or rapid response teams use the same calling criteria as they did in the negative MERIT study. When we look at delayed call scenarios, the delay from from meeting criteria for activating the team, enter into the Meditech, and I'm sorry, that's our system in Toronto, to the actual call made can be as high as 8 hours. In our center, we had, before some improvements, documented up to the 8-hour lag time between entering those vitals, patient vitals, into the computer and then getting a call made. Time to documentation of obtained vital signs can be as long as 8 hours from bedside into the chart. So there's those lags to consider as well. So that leads to some frustration sometimes. So this leads us to the question of, how do we optimize our rapid response team activation? So going out there and doing rapid response team work, going to the bedside and saying, hey, this patient's had abnormal vital signs for hours now. We're just getting called right now at 3 in the morning. It's been a long time. What's going on? How can we optimize the way we work? So we can consider improving the performance of that signal, or what's called in literature the afferent arm, the signaling of the rapid response team. We can hardwire that or use a forcing function. And that's really the rationale for early warning systems and really how it works. It's a way to make sure that when a patient actually has calling criteria, that someone is alerted to that right away. So that brings us to early warning systems. So what is it? It's a systematic and usually computer-assisted scrutiny of vital signs data sets. What the computer will do is look for abnormal patterns that you define that are known to predict bad outcomes. So, but they're not set in stone. And typically you'll go back to literature and say, okay, what are the vital sign abnormalities that predict bad outcomes from my group of patients, be they medical, surgical, pediatric, obstetric. Abnormal patterns of vital signs then are packaged as alerts. So when we started with our system, for example, we use SIRS criteria, and if a patient met 3 out of 4 SIRS criteria, after the nurse entered the vital signs into the EMR, into the electronic medical record, the EMR would just then crunch those vital signs and say, okay, of the vital signs I have, do any of them meet SIRS criteria? And if 3 out of 4 SIRS criteria were met, the EMR would then spit out an alert. And we had a mechanism whereby that alert could be then sent to a provider. And the key is, I think, an accountable care provider has to be sent to the right level of provider. And I think that's one of the secrets of success of the system, and I'll talk that in a moment. The response to the alert is well-defined, it's scalable, and patient-focused. By scalable, I mean the response can vary from, okay, we need to pay more attention to this patient, we're going to increase the vital sign frequency, all the way to we're going to call a code because we think this patient's really sick, and then everything in between that as well. So we can stop there and say, oh, wait. Experienced bedside clinicians, nurses, doctors, RTs, they often have, after a few years of practice, a good intuition, a good intuitive sense about which patients are sick. And so do we really need a computer to tell us who's sick? Sometimes we forget to use our intuition on the wards. There's cognitive overload. There's lots of competing tasks. There's lots of distractions these days, more and more all the time. Sometimes our intuitions are wrong. We have complex patients with lots of different things going wrong. We have overlapping presentations of different diseases. So, sometimes the different diseases mimic each other. We remember the last case we had of disease X, but not the last 100 cases. So our brains are not wired to aggregate all the cases we've seen. We just remember the last few and we think, okay, this one's going to be the same, but in fact, it's not going to be. Sometimes we bend the facts to fit the story we like the best to make the sense of the patient. So sometimes we ignore items of the history or physical exam that we find don't fit with the story we're going to be telling about why this patient is sick. These are just common heuristic errors. They're not a function of intelligence or experience even. Experienced clinicians make the same errors that less experienced clinicians make all the time. So I talked a little bit about this, our complex sick patients. Alarm fatigue is something we have to consider as well. So we don't want an alert from an early warning system just to be another alarm that's going to bother us and we're going to turn off. And sometimes, on our wards, our physician expertise and availability can be quite variable when it comes to managing the deteriorating patient. So we're not great our brains are not great at integrating lots of pieces of information to the big picture quickly. We need to think things through, and sometimes that takes time we don't have. So we can ask our EMR, many of us have these, not all, but our electronic medical record to run a checklist for us, just a checklist, and say, okay, does this patient have SIRS or not? Do they have an altered LOC or not? So often people are entering a GCS or some measurement of level of consciousness into their EMR. You can just tell it, if the GCS is less than this, or if I'm picking a low level of consciousness score, then please send an alert to a provider. So you can design your algorithm to be very sensitive, so to pick up everyone who might be sick, but a lot of them won't end up having a bad outcome, or very specific, meaning you're going to miss some patients, but the ones it's going to pick up are the real deal. They're the really sick patients. So how you set these characteristics is best determined by where you want to assign the accountability for the measurement and response to vital signs, and I'll explain that a bit more detail. The early warning literature is replete with different methods to do this. Which score is the best? Which method is the best? What combinations of vital signs are going to be the most predictive to say, yes, if we use this score, it's going to really tell us who's going to end up in the ICU, who's going to have potentially a code blue, etc. What I'm not sure it really matters. There's 20, maybe now even 30 or 40 early warning scores out there. Seems like a new one every week. They all perform about the same. The AUC, or area under the curve, a way to measure the operating characteristics of like how predictive these scores are. They're all reasonable. Often they overlap with each other. None of them are perfect. Few of them are terrible, and I'm going to say it doesn't really matter which one you choose. There's a lot to pick from, and you choose the one that makes most sense to your centers and your teams. What really does matter is matching the alert to the level of accountability. So before I talk about these studies, if you want to pick, for example, a score that's very specific, so it's going to really identify those patients who are definitely or almost definitely going to deteriorate some way, that's a kind of alert you might want to feed to your rapid response team. Tell them, hey, this patient's sick, and so the rapid response team provider may have a device, handheld device or a phone that's going to get an alert saying, hey, this patient has met calling criteria, this patient has, has SIRS, what have you. You want to give the rapid response team only the highest level of alerts, because otherwise they're going to be everywhere. If you're using a more sensitive, less specific alert, for example, lots of patients on the wards have SIRS, meet SIRS criteria, but only about 15% of patients meeting SIRS criteria will ever go on to have a bad outcome. There you have to be a little more careful. So that's what we did. We looked at SIRS criteria, some mental status criteria, and then we said, okay, if patient's going to trigger that kind of alert, the alert should go to the charge nurse on the ward, not the bedside nurse, because they've got a lot to do. They've already got lots of alarms singing at them. Let's put it one level up to the charge nurse. The charge nurse then gets that alert and goes to the bedside and triggers response, and we'll talk a bit more about that soon. So that's kind of the concept behind what type of alerts are used. So where's the evidence behind this? There's not a lot at this point, but I think it's maturing, as I said. But Ronaldo Bellomo is from Australia, again, another pioneer of rapid response teams and now early warning systems as well. Did a before-after study of 18,000 patients in the US, Europe, and Australia. They used vital sign monitors that were very nice. They got the vital signs by this monitor, inputted the respiratory rate, and then those vital signs were sent wirelessly to the EMR. The monitors then calculated an early warning score, which flashed on the screen and said, do this, call CCR, call rapid response team, for example. So when they did this, they noticed that there was a decrease in time to complete vital signs. Patients with a rapid response team call had improved survival after the implementation. So the odds ratio was about half. So survival improved for patients who did have rapid response team call, and that was significant. And the dose of rapid response team, remember something we talked about earlier, increased from 21 to 24 consultations per 1,000 admissions. And there was a trend to a decrease in cardiac arrest. It didn't quite make significance, but a trend nonetheless, and the improved survival overall, as you see. More recently, Dr. Bellomo teamed up with Dr. Subi, who is from Wales in the UK, and he is probably the pioneer, the originator of the very popular modified early warning system, or the MUSE score. That score has been around now for about 16, 17 years, and they teamed up and did a more recent study in the UK, 2,000 patients, so in each time period, a before-after study, smaller study, but they looked at 2 wards in a general hospital in the UK, and they noticed that after they implemented their early warning system, they had more attendance, so a higher dose of rapid response team attendance in the after phase, and with that, a decrease in hospital mortality, decrease in code blue, and decrease in severity of illness at the time of ICU admission from the ward, and a decrease in ICU mortality of patients admitted with a rapid response team consult. So again, speaking to the importance of a rapid response team dose, and the way to get the rapid response team dose up is to make sure that rapid response team is activated in a timely manner on all patients who meet criteria. They also showed an increased number of patients with DNR orders, and I'm sure those of you who do rapid response team work know that sometimes when you're responding to a deteriorating patient, the appropriate response is patient-family discussions about goals of care, and that does often result in more orders around appropriate goals of care for patients. So as I said before, if you want to make your alert very sensitive, pick up anybody who's going to go on to have a bad outcome. Think about alerting your ward team and perhaps the charge nurse. If the alert is going to be very specific, kind of a high-level alert where it's going to alert for a patient who's definitely sick, almost certainly going to have a bad outcome, you're going to want to alert your rapid response team. And of course, that doesn't prevent your ward team on the more sensitive side, let's say, to alert your rapid response team if they feel the need to do that. And that's where you think about your response arm and your scalability of that. So our system in Toronto is called Aegis, which means shield, and the signal arm is as follows. The vital signs are taken by ward caregiver. They're entered into the EMR. Now, on many wards, they're in fact entered at the bedside into a little mobile vital signs monitor that are sent again to the EMR, similar to one of the studies I showed you. The abnormal vitals are detected by a computer algorithm, and the alert is sent wirelessly to a PDA, in our case, a phone held by a caregiver. And that caregiver is, in our situation where we use a very sensitive, at this time, we use a very sensitive alert, the caregiver is a charge nurse. First responders are the team leader and the bedside RN. Further response is scalable, as I mentioned before, depending on the degree of patient acuity. They might review the patient in morning rounds with the MRP. They might call the MRP right away, call rapid response team. They may call the respiratory therapist, depending on oxygenation issues. Often a trigger for end-of-life discussions as well when someone triggers an alert. And now I'm pleased to introduce Lynn Healy. And Lynn, are you ready?
Yes, I'm ready. Thanks, Dr. Melliton. Nurses today care for patients who have very complex disease processes. Nurses are learning about new technology and treatment regimes on a daily basis, and nurses are very highly task-oriented and manage high volumes of patients with fast turnaround times. In our organization, there is an increased novice to expert staff ratio, and this means that a large group of nurses lack the clinical experience, critical thinking skills, and the knowledge in identifying early signs of clinical deterioration. This slide here demonstrates how our early warning system works. Vital signs are taken by the nurse, then they're documented in the electronic health record, which we currently have Meditech at our organization. And if it meets the preset algorithms, then the alerts are sent to the first responder, which is actually the charge nurse. The bedside nurse is responsible for the vital signs and level of consciousness monitoring as required by the standards or a physician order, or as a result of a suspected change in the clinical condition of the patient. He or she's also responsible for the timely documentation of results. He or she also would want to critically trend the results. He or she would report any changes to the charge nurse or the most responsible physician of any change in vital signs, which would be indicative of a deterioration or a non-improvement post-treatment. He or she would then notify the rapid response team as required, and then he or she would document the actions of the alert in the Meditech or the electronic health record. The charge nurse does have some responsibilities, and it is a benefit to her. He or she receives daily alerts via handheld device, can discuss the alert and the patient condition with the bedside nurse, support and mentors the bedside nurse in clinical assessment and clinical decision-making, supporting novice nurses, and building champions. So all it takes is one save to have their full commitment. Standardizing communication processes. It is a great notification tool of all the sickest patients on the unit, and transfer of accountability between charge nurses. The alerts enable that information to be shared between charge nurses. Okay, so the charge nurse receives daily alerts via a handheld device. We initially started out with an iPod, and we recently just moved over to an iPhone. So it discusses the alerts and the patient's condition with the bedside nurse. It supports and mentors the bedside nurse in clinical assessments. And these are samples of the screens that the charge nurse would see when the alert is received. And it gives you information of each alert type and the contextual data of the patient. It actually guides the charge nurse through what actions to take. And the sample on the right side actually tells them that the patient does meet the rapid response calling criteria. For nursing, these tools help to identify clinical deterioration early so that we can intervene as soon as possible and provide better outcomes. And these actual screenshots are what the charge nurse sees, and it actually guides them and instructs them on actually what actions they need to take. So I'm going to turn the presentation back to Dr. Milliton, and he's going to talk about post-implementation and its refinements.
Thank you, Lynn. I have to mention that Lynn has been absolutely instrumental in the design and implementation of our early warning system, and really takes a huge measure of responsibility for the success of our early warning system, and just a very public thank you to her for that. So I will talk a bit about implementation of our system and some refinements we made as we went along. So we, as I mentioned, we initially included a service criteria as our alerts, and then we, I think, got a little bit smart and realized, hey, we should put rapid response team criteria in there as well, so that when those are met, we're not just relying on somebody making a phone call, but in fact, once those criteria are put into the Meditech or the EMR, then an alert will be sent to the charge nurse, and he or she will know right away that, hey, this person meets rapid response team criteria, and the message will say, as you saw on the previous screen, please activate rapid response. Getting patient vital signs into the EMR in real or near time was a sort of side project that Lynn also spearheaded here, and it was a nice way to leverage the work we were doing in early warning into helping decrease the time that a nurse needed to get those vital signs actually from the bedside into the EMR. It was certainly helped by some capital investment into monitors that would send that wirelessly, but certainly that's not the case at every center. But certainly implementing early warning, explaining to staff how important it is to get those vital signs into the machine quickly so that the alerts can be done and sent if necessary, is definitely a nice side project that has an additive benefit. And I find often these QI projects often spawn more similar projects with nice benefits. We did add in triggers for neurologic deterioration as well. We use an AVPU or AVPU score, given the sometimes complexity of having to calculate a GCS score at the bedside, and AVPU is just an AVP or U, A alert, V, someone who's responding to voice only, P, the patient is only responding to painful stimuli, and U, the patient is completely unresponsive. So if in our system, if the patient is responding just to pain or is unresponsive, then that will trigger an alert as well. So our system is decentralized, so we don't have a significant increase in workload for the charge nurse. The number of new alerts would be about 3 per shift per ward of about 20 to 30 patients. So it makes an average of 6 alerts per shift per ward, and that includes repeat alerts as well. So a manageable workload. As Lynn mentioned, the day and night shift team lead will have enhanced communication about who's sick. Team lead will have increased ward mastery, knowing who her sick or his sick patients are, and also enhancement in nurse to physician communication. the nurse can now tell the physician, hey, this patient triggered an early warning alert, and the physician will, with time and as the system matures, know what they're talking about, and they're speaking the same kind of language, and those triggers will be there to say, hey, you know what, this patient is sick, I should pay more attention, or I need to respond in such and such a way. So our system, we're really quite pleased. We piloted on 6 medical wards, and after a year found a 35% reduction in code blue rates, an 18% reduction in unplanned ICU admissions, and translating about 2 to 4 lives saved each month. In our next phase, we expanded AEGIS, our early warning system, to the remainder of the medical and surgical inpatient units based on the previous success of the pilot. And with that, we have very nice access to ward-specific rates of code blue, death, and ICU transfer. So we can really drill down and compare like to like, because wards are often different. They sometimes have different cultures within the hospital. They look after different types of patients, and it's, I think, most fair to compare their performance to their prior performance. And we can do that. Of course, we can compare ward to ward, but we can also compare each ward to their prior performance, which is excellent, and we track that over time. So we wanted to make sure that our project was sustainable, and we looked at the durability of the code blue reductions seen in year 1. And on this slide, you can see 2 hospitals. One is in blue, the other in red, and these are, again, the 6 original medical wards. And in our first year, we saw nice reductions in our code blue, larger ones that were sustained over the next year, and again, now are coming, kind of meeting each other, and certainly a nice large reduction from before. The numbers on the y-axis are code blues per 1,000 admissions. So we started up in the sort of 8.5 region, now leveling off to between 4 and 5, which was a super improvement and real testament to the work of the team. What drove this reduction in code blue rates? Well, I think when we look back and again, getting back to this idea of a rapid response team dose, you're probably sick of me talking about that, but I think it's really central to this whole concept. We can see a rise in our new consult activity, and this is for both hospitals. So as we implement early warning systems, we can see a gradual rise in how busy our rapid response team was. And I think that is the mediator of the reduction in the code blue rate that you see. So I think the reduction in the code blue rate is helped by the early warning system that drives up rapid response team activity and then gets your code blue rate down. And finally, when we looked at the hospital's standardized mortality ratio, we want to see now, a lot of things contribute to patient deaths or bad outcomes in hospitals, but just taking the sort of the 30,000-foot view, we can see that right where those lines start to meet in 2013-14, kind of the second bar from the left, and that's where we start. And then over time, we see that for the entire hospital corporation, two hospital sites in blue, we see a slow but steady reduction in hospital standardized mortality ratio since introduction of the system. I don't think there have been any other large-scale quality initiatives to compete as an explanation for this. Of course, we'll try to be modest. We won't take all the credit, but I think certainly some credit is due to Lynn and her team in terms of helping create this really improved situation for improved patient safety situation for all our patients across the corporation. In summary, an early warning system can increase ward nursing accountability, improve patient safety by triggering a provider response earlier in the trajectory of a deteriorating patient. Early warning systems can be used as a forcing function to ensure that rapid response teams are activated and activated early. Timely rapid response team activation is associated with better patient outcomes. And that concludes my presentation. I'm going to now turn it back over to Lynn.
Yes, thank you. Thank you for your great presentation. So at this time, we're going to be starting a question and answer period shortly, but I just have one more announcement. So we have continuing education for nurses and respiratory therapists. So this activity has been approved for 1 contact hour of CRCE and CNE by the AARC and California Board of Nursing and the Florida Board of Nursing. Go to saxtesting.com/BO. You will need to register on the test site, complete the evaluation form, and upon successful submission, you'll be able to print your certificate of completion. The accreditation statements are listed below. The on-demand version will be accredited for CRCE and CNEs. Okay, so we've got to the question and answer period, and we've gotten a lot of great questions from the audience, so I'm just going to open it up so that we can answer some of your questions. So I do have one here from Brandon. He's asking, is the early warning system available on the Epic patient documenting system? And if so, is there a cost for activating their early warning system service? So I don't know, Dr. Milliton, if you're able to answer that. We currently use Meditech at our organization, so I'm personally am not aware if Epic actually has an early warning system built in.
I can't answer specifically in terms of Epic. I do know that a lot of these EMRs have different generations coming out, and as early warning systems are getting more and more popular and really proving themselves, more of the vendors are jumping on the bandwagon. So does Epic have this? I don't know. Could it? I wouldn't be surprised if it did, or it would be coming soon. As something you'd need to check with your vendor, I think.
Okay, thanks. So I do have one here from Jason. He asks, how do you deal with delays in data entry for the vital signs? And do you have protocols in place to mandate data entry of vital signs within a certain period of time after they've been collected? So I can actually answer that question. So when we first started out with the early warning system back in 2013, we definitely had delays in data entry for vital signs. And sometimes we were seeing delays up to 8 hours. So the nurse would do vital signs first thing in the morning, and then it wouldn't be until the end of her shift that he or she found some time to document into the electronic health record. So we went through a whole bunch of educational blitzes and really try to impress upon the nursing staff to input their vital signs as soon as possible. And at that point, we were asking for a 1 hour at the most time delay. Probably for the last couple of years, we've actually moved to point of care vital sign machines where it will electronically send to the electronic health record, and we're actually generating alerts to devices within 2 minutes of the input to vital signs. So we have made some really great improvements in terms of delays into data entry. I don't know if you have anything to add to that, Dr. Milliton?
No, not at all, Linda. That's
okay.
That's been a real testament to the improvement for sure. Yeah.
Okay. So I have a question from Harold. He's asking, how often do early warning systems lead to false results, and does that lead to alarm notification fatigue?
Do you want me to take that one, Lynn?
Sure, I can start with that one. So we don't often have false results because our criteria are very specific to the vital signs that are taken. So say, for example, we get an alert that says a blood pressure is greater than 199. So perhaps a vital sign was 200 over 100. So that in itself is not a false result. And so we are not getting a lot of alarm fatigue. What actually does generate through to the iPhone or the iPod, depending on what device we were using, is a true alert. And if every time the nurse does a vital sign and the blood pressure is still greater than 199, those alerts are valid. So I can only speak specifically for our type of early warning system, but we are not finding that there is any alarm fatigue.
Yeah, and the way our system works, is that, of course, SIRS, as I mentioned, SIRS criteria do occur commonly, and most patients who have SIRS may just have it transiently and then get better, and may never, and most of those patients never have a bad outcome. However, the way our alerts work is that, of course, each ward has a charge nurse, and so those SIRS alerts will go to a charge nurse. What you want to avoid is, of course, getting every patient with SIRS in your hospital alerting to one device or to one person, because that's going to cause alarm fatigue. If your hospital has 10 wards or 20 wards, and 3 of those 20 patients are triggering, have SIRS, that's going to be a lot of that's going to cause alarm fatigue. But if you can work out a way, and in our system, it was not difficult for your IT folks to decentralize the alerts, meaning that each phone carried by a charge nurse will only get alerts from that ward. So let's say from our neurology ward, where Lynn started out, she would only get alerts from that ward. The cardiology charge nurse would only get the alerts from their ward. So you kind of decentralized the system, so it became the alerts, and let's say the burden of alerts became manageable. When you move to a very specific system, meaning very high-level alerts, calling criteria for rapid response team type of alerts, those are fewer in number. Those are more specific, and those can be fed to one provider, potentially like a rapid response team person. And that's going to be the next phase of our continuing QI project in early warning.
Okay, so we just have time for a couple more questions. So there's another question from Harold. So he's asking, is there a clear data that demonstrates improved patient outcomes for the use of both early warning system and rapid response teams versus rapid response teams without early warning system? If so, what was the size and scope of the study?
So the 2 studies I mentioned earlier, both by Belomo, one, the 18,000 patient study in the US and Australia, these are before-after studies. So essentially the hospitals have rapid response teams, and they look at outcomes for a year, and then, or 6 months a year, and then the post phase is early warning plus rapid response. I'm sorry, I may have not been clear with that. And in the post implementation phase, meaning after you add an early warning system to your rapid response team existing system, you see these reductions in inpatient code blues, these reductions in inpatient deaths, and a higher dose of rapid response team activation. And so now that's been shown in 2 before-after studies, but it's true, admittedly, the early warning concept has not been submitted to a rigorous randomized controlled trial. Not yet.
Okay, so last question, and this one's from Gail. So is pulse oximetry results taken into account for looking at the need for early warning?
Lynn, do you want to talk to that?
So the answer is no. So we have not included pulse oximetry in our criteria. I'm not quite sure why it wasn't included, but perhaps you could speak to that.
Sure. So the pulse oximetry one, it's a bit variable. You tend to get a lot of false positives, I find. On the other hand, it's also increasing oxygen requirements are something that is commonly recognized, I find, by nursing staff often early. So someone goes from a couple liters of oxygen to 50% oxygen. Usually, I find, at least in our center, most nurses, even novice nurses, are aware that, hey, that's something's going on, and a response is triggered. Some hospitals already have existing protocols about, if patients on such and such amount of oxygen, please call, provider X, Y, or Z. Nevertheless, there has been, there have been questions from nursing providers at our center about that. SIRS criteria, as you know, do not include an oxygenation piece. So in our next phase, will be including oxygenation criteria using an aggregate score like similar to the Muse score, which has oxygenation and so what the patient's saturations are and how much oxygen they're requiring. When we're going back and auditing those kind of alerts, including oxygenation, I have to say that it's at least in our experience, it's not buying us a lot, because I think those patients are already well on everyone's radar screen.
Okay, so unfortunately that's the end of our question and answer period, and I just want to thank everybody for submitting your questions, and I'm going to turn the presentation over to Emily for a few final points to discuss.
I would like to thank you very much for your time, both Dr. Milliton for this very informative presentation, and as well to you, Lynn, for being our moderator today. It's been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well as those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time